All right, thanks for having me. So why don't I dive right into what we're doing? Here are some of the funders for the research that I'm going to be presenting here. Um, and these are my collaborators on this. I'd particularly like to point out Senpei and Marta Galanti, who are in my research group, who've led a lot of the modeling efforts that I'm going to be talking about right now. Obviously, there's a collaboration with Pfizer that you're going to be hearing about as well over the course of the talk. I'm actually going to get really pedantic, I guess. I'm going to start talking about definitions so that we're all on the same page. One of the things that's been interesting about this pandemic, amongst many things that are there, as well as it being horrifying, is the way it has elevated epidemiology into the common vernacular. There are a lot of terms out there. There are a lot of understanding of these terms and people understanding things like the basic reproduction number now within the lay public that we hadn't seen before, really. Um, but it's important to understand that there are quite a lot of these epidemiological characteristics that we can talk about, and some of them are very interesting. And one of the things that we try to do with the data that are available at population scales is to make sense of the larger characteristics and transmission dynamics of this virus as it moves through populations, as it changes in both space and time by estimating these characteristics. So I'm going to go through some of the characteristics that we're going to be looking at in a moment, or that inform what we're looking at in a moment. And then I'm going to talk to you about a model inference system that we built to estimate these characteristics over the course of 2020 in the United States through time and resolved at county resolution. So the first one, of course, is this basic reproduction number, R naught, which is the average number of infections generated by an infectious individual in a fully susceptible population. So you take somebody who has this virus, you plunk them down in a community that is fully susceptible, and the average number of persons that that individual infects over the course of their infection is the basic reproduction number. However, there are some other reproduction numbers that are very important and have been bandied about and have to be considered. The next one is something that we refer to as RT, or the time varying reproduction number. And the reality is the basic reproduction number is in some ways not an immutable quantity. It changes in time and space. There are modifications of it due to structural, seasonal, and behavioral changes and differences. So for instance, the basic reproduction number prior to shutdown in a place like Manhattan, New York, is very different than the basic reproduction number in some rural community, let's say in East Texas, all right, or West Texas or Eastern Montana, place where it is ranches, car cultures, and on any given day, you don't run into nearly as many people as you or I might if we're living in New York City and getting on the subway and walking around a lot and running into hundreds, if not thousands of people in a day. So right out of the gate, there's a difference in the basic reproduction number when you go from place to place that varies based on things like population density, housing, public transportation access, structural features that vary from place to place and set a different limit on what that basic reproduction number is. Now, furthermore, some viruses have seasonal components to them that are extrinsic to the host virus dynamic. So for instance, something like influenza is thought to be modulated by absolute humidity conditions. It seems to survive better when humidity conditions are dry, and that seems to favor its transmission in the wintertime and phase lock it so that we get these seasonal outbreaks that manifest in the wintertime. That's a characteristic that we can't really control, but it does seasonally modulate that basic reproduction number, and it has to be depicted by a time varying reproduction number. And the last one is the behavioral changes, and that's something that we've certainly seen in spades for what's happened over the course of this pandemic. We've had lockdown measures enforced, we've had mask usage enforced or not enforced. In addition to shelter in place orders, we have social distancing, restrictions on mass gatherings, closing of businesses, partial opening of indoor dining, etc. Now, these are both policy driven and compliance driven based on what the characteristics of a local community are and their willingness to adopt and enforce things such as a mask mandate. So all these factors are coming in and they're changing the reproduction number. So it does not stay fixed over time nor in space, and this is represented by RT. There is a third reproduction number, however, and that is called the effective reproduction number. And this is the estimate of the actual transmission potential of an individual in a population that accounts for all those factors we just talked about for the time varying reproduction number, but also population susceptibility. If you remember, basic reproduction number assumes that you take an individual and you put them in a population that has no pre-existing immunity. That is not the case as we evolve through this pandemic. Obviously, there's been a depletion of susceptibles. People have been infected, and at least for some time period, we have evidence of adaptive immune response that is robust and protective. So if you're going to factor that in as well, what you do is you take the time varying reproduction number, you multiply it by the fraction of the population that remains susceptible, and that provides an estimate of the effective reproduction number. Now that should be the actual estimate of what's going on in the community. The actual number of people an infectious individual should currently infect in a place like, say, New York City right now, or Seattle right now, or London right now. Whatever your city, whatever your location, the effective reproduction number is an estimate of how many people are going to be infected by an average infectious individual. This is the critical number that has to be below 1 if you want to start driving the virus down and eliminate it locally. And if it's above 1, it's the critical number that determines growth of a pandemic or an outbreak in a community. Now, there are other factors that we need to think about. Certainly, one of the big ones is the ascertainment rate, and that is the fraction of all infections that are observed. So confirmed cases are our observations. These are people who are diagnostically confirmed with any number of tests that are out there at this point, but only a fraction of all infections actually are ever tested and confirmed. What is that rate? This is very important for understanding the overall prevalence of infection and how many people have actually encountered the virus. It's important, of course, for understanding what's going to happen with vaccine deployment as well, because you want an estimate of how many people have actually experienced infection and perhaps already had an adaptive immune response. Another one is the community infectious rate. This is a measure of prevalence, and prevalence is the number of people who are currently infected. But in this case, we're looking at the number of people who currently are contagious. They're actually harboring active infections. And in the case of something like SARS-CoV-2, there is a latent period where the virus is replicating within a host and the person is infected but not yet contagious. They're not shedding enough of the virus to actually be contagious. Where exactly that point lies is something that we don't know precisely, but we would like to make an estimate of how many people in a community are walking around and currently contagious. That's something we would really like to know. Then something else that we hear about quite often, the case fatality rate, and that's just simply the deaths per confirmed cases, per confirmed case. This is something also that is not immutable. It changes in place and time. And so you can estimate it for an entire nation, or you can estimate it for a locality. More specifically, we often want to know the infection fatality rate, which is harder because you have to estimate the total number of infections. This is where that ascertainment rate becomes very important, whereas the case fatality rate can be roughly estimated by just looking at confirmed cases and confirmed deaths. The infection fatality rate has a denominator, total infections, that has to be estimated. And lastly, population susceptibility. We would like to make an estimate of what fraction of the population remains susceptible, has yet to be infected with this pathogen. Now, certainly, if you can get the ascertainment right and estimate total infections to date, then you have the chance of just really simply getting an estimate of population susceptibility and know how far the reach of this virus has been thus far and how many more people are liable to being infected. All right, so this is sort of the swath of epidemiological characteristics that we were thinking about and we would like to consider and try to understand what this virus has accomplished over time, in particular over the past calendar year, 2020 in the United States. So what we did is we developed an inference framework, which is something that we often do, that's comprised of a mathematical model that represents populations at the county scale. This is called a metapopulation model. Within it, it tracks both documented confirmed infections and undocumented infections. It allows mobility between locations, and that's what makes it a metapopulation model. So they're all linked by rates of movement that we first got from Census Bureau estimates early in the pandemic, but very quickly afterwards had to switch to things like location-based service data that we get from organizations and sources such as SafeGraph, which give us an indication of how much people are moving out and about and between counties. Now, this whole system is coupled, the whole model, the mathematical model is coupled with a Bayesian inference algorithm that allows us to ingest confirmed cases and inform the model states. Now, the model states are things like the number of people who are currently latently infected, the number of people who are infected who will be confirmed, the number of people who are infected who will be undocumented infections, and the number who are susceptible. The reality is that we only observe documented confirmed infections, those who are actively infected with a virus on a given day. We only have this single observed quantity, which actually doesn't quite align with what the model is tracking dynamically within its framework. But what we use the Bayesian inference algorithm to do is to assimilate that data and to use it to provide a best estimate of the characteristics within the model, both its state variables and critical epidemiological parameters within the model, so that it can estimate those and provide us some sensible solution or fitting of the model to those observed data that is the best solution that matches what has been observed. Now, that best solution, then we can peel back and look and say, all right, well, how many people were latently infected? What is the ascertainment rate within the model? How many people remain susceptible? So within this inference framework, we're going to estimate everything that is unobserved. Now, the question, of course, is how well can we do this? Is it an identifiable system? The system is actually high dimensional and there are a lot of parameters in it. So at micro scales, for some of the counties for which there aren't a lot of observations, where there aren't as many cases, it's not going to work as well. At aggregate scales, as you ratchet it up to metropolitan areas or states, you aggregate up to regions, it is going to provide a robust estimate of what's going on. And we're going to produce some validations and cross validations in order to show and demonstrate that it can actually produce observed behavior. So this whole model system is run at county scale, and we're going to provide daily estimates of those characteristics I talked about in depth at the beginning of this lecture. So here's the fitting that we have right now. This is a fitting, and I'm just showing you the national daily cases, and it shows you those as the blue dots. The median fitting is shown as the thick black line, and the 95% confidence intervals are shown around it as the dashed dot lines. And you can see that we actually do get a very reasonable fitting over the whole course of the pandemic at national scale, capturing the spring, summer, and then the fall, winter outbreaks. Now, we also have looked at this for representative metropolitan areas. So this is the New York metropolitan area of 12 counties, including the 5 counties of New York City itself, plus 7 surrounding counties. And you can see the fit that we obtained there for the outbreaks that manifest in that specific locality. And you can see that there wasn't a summer outbreak, but we had a large spring outbreak and then a fall winter outbreak as well. And this, we've also looked at places like Miami and Phoenix and Chicago and Los Angeles, and we're seeing similar quality fittings. So from first blush, in terms of being able to replicate the observed behavior, in terms of the number of cases that are confirmed, the model is doing a very good job, both nationally and at metropolitan scales. However, we also wanted to cross-validate this system with data that were completely external to it, that we didn't use for actually fitting the model. So what we did is we took CDC's estimates that they posted on from seroprevalence surveys conducted in 10 different locations over a course of time. And we saw how well our estimate of the cumulative infected population matched with the seroprevalence estimates we got from those surveys. Now, we had to adjust the seroprevalence surveys because we know there is a small amount of waning of antibodies that would be detectable. So we built a model that actually does that waning. So we fit that waning into it, and that's what you're seeing, and that's why it says adjusted seroprevalence there. And what you can see is the match between the model estimates and that adjusted seroprevalence. The colors here show the date at which the sero survey was conducted, and it ran from before March 1st through the middle of August in this instance. And you can see that it's actually quite a remarkably good fit. The R squared, or the R value, is 0.97, excuse me. So this is a reasonable cross-validation that external to what we use to actually fit the model and perform this inference estimation problem, we also were able to cross-validate it at different locations with estimates from sero surveys. Now, if we then peel it in and look at some of those characteristics that we wanted to look at, things like the ascertainment rate, what we can get then is an estimate of the time evolution of this. So what you're seeing is box and whisker plots of the daily values shown for the month over the course of time. Now, I should stress that actually these are monthly values, excuse me, not daily values, that when we do this inference, the inference is performed as an ensemble, and that's why we have uncertainty. The same way back here that we have these credible intervals around the median estimate that you see there that's shown in the dashed dot lines, we're also going to get uncertainty associated with all our estimates of the individual parameters. And that's what you're seeing in the box and whisker averaged over the whole month of March through December, as shown here in 3 through 12. So what we see is at the national scale, the ascertainment rate was quite low during the month of March. It was down about 11% is the median estimate, and it rose over time up to above 20% by the time we hit June. And more recently, it's climbed all the way up to almost 25% by the end of 2020 in the month of December. Averaged over the whole year, it's about 21% of all infections that we estimate were actually confirmed cases. And this is a weighted average that takes into account the number of cases that were actually occurring over time. And this is actually consistent, of course, with what was happening early in the pandemic and happening later in the pandemic. Early in the pandemic, we had a limit number of diagnostic tests available. There were even limits on who could be tested based on travel patterns, whether somebody had been to Wuhan, China, or in contact with somebody who had themselves been in Wuhan, China. Ultimately, once we got to the summer, capacity was ramped up, availability was broader, labs had better throughput, and we were able to test more individuals. And with the prevalence of it in people's communities, there was more engagement and desire to be tested. But again, this ascertainment rate is showing you the fraction of all infections that were in fact documented and confirmed. And our estimate is really roughly about, for the whole of 2020, only 1 in 4.6 infections was a confirmed case. Now, if you look at the other plots, it shows you the same time series, but for different metropolitan areas, New York, Chicago, LA, Phoenix, and Miami. And you actually see some real consistency there. You know, LA starts much lower, well below 10%. In March, there wasn't nearly as much activity and never rises quite up to 20%, whereas Phoenix rises up above 30% by the end of the year. So there are some differences as you go place to place, but the overall picture is consistent among localities, reflecting sort of a national capacity to administer and process tests. Another one that we really want to look at is population susceptibility. This is also, of course, very important. And this shows you how our estimates of population susceptibility changed over time. Nationally, we estimate that at the end of the year, about 68% of the population remained susceptible. That is, they had not been infected as of yet. Obviously, in December, we had a limited beginning rollout of the 2 mRNA vaccines. It makes a very small dent because by the time we got to the end of the year, I think only 3 or 5 million doses had been administered. So it was very limited over the last few weeks of December. So ignoring that, but population susceptibility estimates were roughly that 1/3 of the population had been infected and 2/3 of the population had yet to be infected. You can again see different time courses for the different metropolitan areas that we're highlighting. You can see how Los Angeles was particularly ravaged at the end of the year in November and December as the outbreak took off, so much so that it was under 50% of the population remaining susceptible by the end of 2020. You can also see in the maps the estimates on August 1st and December 1st at a county scale within our model estimates. You can see that, you know, there are some pockets in August 1st that seem to have low susceptibility for the most part, even though there is that summertime outbreak happening in the Sun Belt. We're not seeing huge depletion of susceptibility, certainly more so if you look at the Southeast and the Arizona Southwest area. But when you move over to the lower right, and you see what it looked like in December 1st, you can see how in the upper Midwest and places like the Dakotas and Minnesota and Wisconsin, that there was enormous penetration of the virus within these communities. And in fact, if you look at some of the counties in the Dakotas, 1 in 6 individuals has been a confirmed case. We also want to look at this community infectious rate. And the community infectious rate, again, is this measure of prevalence, but restricted to those that are actively infectious. And we can see how this evolved over time. The blue line shows confirmed cases, which is on the left axis for both the big plot and the inset for the New York metropolitan area. And on the right side, you're looking at the community infectious rate, this prevalence estimate. And what you can see is that as we went along, the number of people walking around, the percentage of the population harboring an active infection on a national scale was under 0.4. So, well less than 1 in 100. It was pretty low. However, by the time we got to December 1st, it was approaching up to 1%. In other words, 1 in 100 persons at the national level was walking around with an active infection and was contagious based on this estimate. And if we looked in particular communities, such as the Los Angeles metropolitan area, this rose up to almost 2.5% in the middle of December. 1 in 40 persons was walking around with an active infection around December 15th in Los Angeles metropolitan area. Remarkably high rate of infection within the community. And of course, we want to know the case fatality rate and estimates of the infection fatality rate. In particular, what is the rate of people actually succumbing to this infection? The case fatality, as I said, is fairly straightforward to calculate from observations, but the infection fatality rate requires this estimation of the total number of infections. And what you can see is that the red line, the infectious fatality rate, it varied over time. And this is not surprising, and it's also not surprising that in general it drops off if you look at the national scale over time, that there are surges that are associated with some of the outbreaks with a little bit of a lag. But overall, the standard of care has improved as we've come to better understand how to manage patients' health in hospital and as treatment options have improved over time. So we can see that depletion that's there or that drop in the IFR. But one of the things that's important to recognize is that early on during the surge of the pandemic, there were locations where the infection rate fatality rate was above 1%. You can see this for New York City. You can see this for Chicago. You can see it happening in the summer wave in Phoenix. However, by the time we get to the end of the year, it'll settle down to a level that's about 0.3%, okay, which means 3 in 1,000 persons who are infected with this virus will succumb from it. That rate is about 10 times higher than our estimates for seasonal flu. So it's important to keep that in mind, that this initial pandemic surge is much more deadly. So briefly, I'm going to touch on one other thing because I know I started late and I don't want to run too much over. We also have been looking at vaccination scenarios. This is something we've done in conjunction with epidemiologists at Pfizer. And what we were interested in understanding is the deployment of vaccinations. How well was this going to help us avert infections and deaths in the population? And what were the things that were going to advantage us so that we could avert more infections and more deaths? So what we've run is a number of scenarios. We took that very model that you just saw and ran it up through, in fact, January 10th. And then at January 10th, we made an assumption of a number of doses being administered each week. In this case, 5 million doses of the Pfizer and Moderna vaccines over the course of a layout that followed ACIP protocols and prioritized certain groups in accordance with CDC recommendations. So there's a whole scenario of running this out forward in time, okay? And we can vary that, and we do vary that quite a lot. But in this instance, it's just going to be 5 million doses going forward, following the ACIP recommended distribution of vaccine over time. In addition, though, we're going to vary the amount of non-pharmaceutical interventions in place, which means we're going to vary that time-varying reproduction number. As I talked about at the beginning, the basic reproduction number is modulated by our behavior, the policies and compliance with those policies that are affected in order to control the virus are going to reduce the basic reproduction number. They're going to reduce as a consequence the intensity and magnitude of a particular outbreak, and they're going to temporarily suppress that herd immunity threshold that we hear so much about. It's very much tied to that time-varying reproduction number. So what you're seeing here are a number of scenarios listed in the upper right. The scenario that is S naught is that NPIs are relaxed immediately, and there is no vaccination. This is a baseline. What you can see in the lower left plots under the SI column is the estimate of the attack rate and the death rate. If we look at the attack rate, it's 0.44 in the estimate. That is the estimate of the fraction of the US population, 44% in this instance, that will be infected from January 10th forward. It's already, and not including the 33% of the population that has already been infected with the virus. This again assumes no vaccination as a baseline scenario. So we relax MPIs, we assume a basic reproduction number of 2.8 in this scenario, and we see how it plays out in terms of the number of infections. That's our reference. We then say, okay, well, what if we relax our non-pharmaceutical interventions completely, but we deploy the vaccine as shown in the A plot? In that instance, we see a reduction in the attack rate and the death rate. And you can see that in the box and whiskers in the S1 column. You can also see in the C and E tables, the number of infections averted or the fraction of infections averted relative to that S0 scenario. So it's about a 12% reduction in infections and nearly a 20% reduction in deaths, more deaths because we're prioritizing higher risk groups earlier in the vaccination scenario. Then you're seeing other combinations going forward where we maintain MPIs as they're currently estimated to be in place as of January 10th, where we strengthen them in the S4 scenario to try to control the virus better, or where we keep them currently but put a lot of doses in a lot of arms and then relax them. What you can see is that the S4 scenario, where we strengthen the NPIs, results in the most averted infections and deaths. And this makes sense because if you put the NPIs in place, you're going to slow the progression of the virus, you're going to limit the number of infections acquired, and you're going to allow the vaccine to better outpace virus in terms of getting at people. In other words, the vaccine is going to get into more people's arms before they get the virus if NPIs are strengthened. So you can see in the S4 scenario, 64% of infections are averted from January 10th onward, and nearly 3/4 of deaths would be averted if we were to strengthen the non-pharmaceutical interventions. So this is something that the New York Times actually picked up, and their graphics are a lot better than ours. So just to show you what this looks like, this was a set of simulations that showed based on what you just saw in the previous one, and it's showing that if restrictions on NPIs are lifted, if we completely relax them, you can see in the right plot the number of additional total infections that would take place because of this lift, allowing us to go back to that basic reproduction threshold, just assuming it's simply to be 2.8. There are also a number of other scenarios that we ran, and again, this is the New York Times showing it. You can see the 29 million additional infections if we lifted our NPIs in the beginning of February. If we lifted them in mid-March, we're still going to see additional infections. If we strengthen our NPIs earlier, we're going to do better. If we strengthen them for longer, we're going to do even better. And it's going to, very logically allow us to get the vaccine in people's arms before they are infected. There's another shot of it, just showing you it in a different graphical form, but the message is basically the same. We have a race between the virus and the vaccine. If we can slow the virus, the vaccine is going to be put at an advantage, and we're going to inoculate more people before they encounter it. We're going to reduce infection, reduce cases, hospitalizations, and deaths. Now, we also tried some other scenarios, and this includes, well, what if we ramp up the rate at which we distribute vaccine? Instead of 5 million doses a week, what about going all the way up to 13 or down to 3? And yes, there are benefits because it's a race. If we can ramp up the distribution and administration of vaccine as well as the production, then that will certainly benefit us as well. I like to point out that, if you were to look at a country like Vietnam, which has done a remarkable job at controlling the virus, they've had 35 deaths and less than 2,500 cases to date. And obviously the pandemic arrived in Vietnam very early in 2020. It's been there for more than a year. That is a place where the NPIs have managed to control it. And if they can get the vaccine and start to distribute it and vaccinate their population to a high percentage, they will be a shining success story of how control of this virus through non-pharmaceutical interventions limited its access to people, and then they were able to use an effective vaccine to protect their population from the effects of unprotected exposure. All right, so I will stop there, and I'm happy to take any questions if there's time.
Jeff, great, thanks. Thanks so much. I have one question just before we probably move on. I didn't get a sense of whether we can know what proportion of the infections can be attributed to super spreaders or outlier people that are, misbehaving. that are, going to bars and going to huge groupings of people, and how much of it is rather just due to the average behavior of people?
So this works off of the average behavior, though it is a distribution. Within it, it has exponential distributions, which implicitly are allowing for super spreader events to take place. It is a stochastic integration within it. So super spreading does happen. However, the model is not structured to specifically make estimates of that. So that's not a quantity we're looking at. And certainly there is a sizable literature showing that super spreading is a very important event in this for this virus.
But meaning you're assuming some bell curve of behavior.
It's actually an exponential curve of behavior. Yes.
Right,
Yeah.
right. Okay.
Yeah.
So we have one question in from Andy Marks. What is the potential impact of the variance on the model?
That's a great thing. I mean, that adds complexity to the whole thing. So if we look at this and we think about vaccination, and we have a race between the virus and the vaccine, and our aim is to get the vaccine in as many people's arms as possible before they're exposed to the virus, part of what we did is predicated on the assumption that this is a highly efficacious vaccine. And as new variants come through, you are going to erode that potentially. Now, whether that means a partial reduction so that, severe infection is still precluded, but higher shedding rates, more transmissibility onward when somebody has received the dose. These are all complexities that are going to come in and have to be dealt with from a public health vantage, unfortunately, and it will potentially be problematic. This gets to the issue of how does this ultimately settle into endemic pattern? What are we going to be dealing with? Are people going to be repeatedly exposed to this virus over the course of their lifespan? And are we going to be on a war of trying to produce vaccines that are protective to the latest variants that have escaped and emerged and are causing problems, kind of like flu? So is it going to be more like measles, or is it going to be more like flu in the sense of how our vaccine arsenal is going to protect us against the variants that might arise?
Right. I mean, the extreme version of the variants is that they're effectively an entirely new pandemic with zero, control by the vaccine. I don't think that's the case, but
yeah, that would be the nightmare scenario. Maybe the more likely one, and this is just me speculating, would be that it's going to be much more like the flu or coronaviruses, and that prior exposure is not going to stop escape and reinfection, but it's going to result in a greater likelihood of mild outcomes.
It's a sort of related. Molly Przowski asked, does it matter if S over R is not binary, but there are degrees of susceptibility in the population and thus RT? Yeah. So if it's a graded thing.
Absolutely. This gets sort of into the same sort of heterogeneity and what might feed into being a super spreader. And dealing with that for this type of exercise is not something that we're going to embed. It is something that potentially could be important. So heterogeneities in networks, heterogeneities in individual shedding rates, heterogeneities in individual susceptibility, these are all factors that in theory can impact some of the outcomes. But the evidence of where we lie on the spectrum and to do this in a data-driven, informed way is difficult, and that would make the inference problem really intractable if we were to try to include some of those heterogeneities right now.
So one other, there's lots of questions. You're going to have to answer them after we're done. But one from is, does the model allow you to estimate the degree of seasonal forcing?
No, and that's one of the, that's a very good point. So when we're making this estimate of the time varying reproduction number within this, seasonality is going to be embedded with it. The things that are contributing to that seasonality, some of which are structural and vary from place to place, some of which are behavioral and have to do with policies, masking, social distancing, et cetera. There's this third element, which is the seasonal aspect of it. And this virus does appear to be seasonal, as the endemic coronaviruses are, and in a fashion that's very similar to influenza. So the question is, do you want to structurally impose that in the model, or just let it be estimated on a day-by-day basis? We chose the latter because that adds for maximum flexibility, but it doesn't allow us to disentangle how much of the change we're seeing that's due to seasonality versus policy and behavior.